Welcome guys to lecture number 2 in the injury management series. While we're going through this lecture, just a reminder, a couple of key documents that you might want to have handy. These can be downloaded from the Moodle website, or you would have been given a paper copy in class. The first and most important of those documents is this one here, which is the test preparation document that we've been working through in lecture 1. We're up to question 11. On this right now, and we'll fill in the remaining information that we need, and this will make up the testable information that the assessment will cover. So once we're finished with the lecture, studying up of this form here will be all you need to be successful in the assessment. Other things you might want to have on hand is this document here, so get yourself in working order from the ACC Sport Smart series here, and we'll just be looking at a couple of pages from that when we get into some of these little acronyms that are used in injury rehab. Probably also good to have the concussion document that's again found on Moodle or given out to you in class. We'll be pulling some things off this one too. So with those things handy and ready to go, we'll jump back into the Prezi here and get started. So in the first lecture we were covering different classifications of injury, from acute to chronic. We looked at soft tissue and hard tissue, and as part of our soft tissue studies, we've covered already ligament sprains, muscle strains, and tendon-based injuries as well. Today we'll finish that off. We've got hematomas to cover, also concussion, as some different injury classifications there, and then we'll actually move more in towards treatment and prevention strategies. So a lot of this stuff is quite common sense. The preventative measures in particular. So we'll be able to whip through that stuff pretty quickly, and I'll, as I said, get you guys to transfer across the key information to your test preparation document, and that'll put you in good stead for the assessment. So we'll dive into it. So what is a hematoma? A hematoma is a localized collection of blood, usually pulled behind a clot, meaning that there's been presumably some impact to a limb or a body part. That impact has caused the rupturing of some blood vessels, probably within muscle, and those blood vessels have leaked blood for a period of time into a space where blood usually doesn't reside. And this is most commonly the space between muscle and the skin, where a layer of fascia exists there. So that blood pulls into that space, then the clotting occurs within the ruptured blood vessels and stops the blood flow from coming in. But that blood that is effectively leaked into that area has now been trapped, and we can see it through the skin as this sort of bluey, blackish sort of colour here. So hematomas can occur anywhere in the body. In minor injuries, the blood's just simply reabsorbed, unless of course the skin's broken and an infection develops, and that can turn into quite a complicated recovery process. But normal bruises, which are also hematomas, we would typically expect them to heal over a period of days, and in large cases maybe a couple of weeks. What you'll notice usually when a bruise or hematoma is starting to heal is that the outside areas, the bits furthest away from where the blood seepage occurred, will start to discolour. So they'll go from sort of a blacky blue colour to a greeny yellow sort of colour, as more of those blood cells that have been trapped there are reabsorbed by the body. And you'll be left, I guess, with an ever-decreasing bruise, which will get lighter and lighter in colour until it disappears completely. Common forms of hematoma that you'll be aware of, other than just normal bruises, will be things like black eyes and hematomas that form under the fingernails as well. Cauliflower ear is another example of a hematoma that's usually seen by people that have repeated friction or impact to the ears. So you're talking front rowers and forwards that constantly rub up against other humans and other body parts, causing a thickening inside the tissue, which is again blood seepage into space where it normally wouldn't be. When there's a fracture, bone fractures bones have decent blood flow, so have blood vessels within them, and a fracture would usually result in some blood seepage there as well, and a hematoma forming in the crack initially, which will actually start the process of bone recovery. Probably the most worrying hematomas would be those that occur inside the skull, and that is cause impact to the brain. which can have more serious consequences than one to your arm or leg or other place. The management of a hematoma is the same as for most soft tissue injury, and that is applying the Reist method, something we'll come across soon that I'll spell out to you properly, but it's essentially the application of ice and compression, the same way you deal with a sprain or muscle tear. If the area is still painful after that 48-hour sort of initial healing period, then you may want to encourage some blood flow to and from the area. That could speed up the removal of those trapped blood cells. So once the clotting has occurred and sort of stabilized that blood vessel that was broken, we can start to think about bringing some gentle heat back, bringing blood to the area, and then maybe cool again and get blood to go away. And we can apply that process in a heat-cold sort of contrast situation, and that should increase the clearance of those blood cells that are not wanted in that space, and also bring along some of the good healing qualities that blood brings with it too. Pressure is also another great thing to get onto that impacted area as soon as possible. The more pressure that's applied, the less bleeding that's going to occur, and therefore the less recovery is going to be required to get that trapped blood away from the site again. And just a reminder again, if there is broken skin and the person also is showing symptoms of fever or sweating and that kind of thing, or there's any incidence of pus or redness and intense soreness around the area, then probably best to go see a doctor and make sure there's not an infection amongst that there. And of course, any intracranial hematomas that would usually be present with a decent knock to the head, potentially even some squishy skull space, which would indicate a fracture of the cranium, where it's way outside of our professional expectation to do something about that, so we would of course refer them to the appropriate medical professionals. Okay, so just before we dive into concussion, we'll jump back into our test preparation document and just fill in the relevant part here, question number 13, which says define the term hematoma. It is of course a localized collection of blood trapped behind a clot. So guys, once we've defined the term hematoma here, we need to give two methods of treating the hematoma. The first one, of course, is the application of ice and compression. And then after 48 hours, we could consider the heat, the gentle heat and cold contrast process to try and actively encourage blood to come and take away these additional blood cells that are pooled in this place. So the last of our injury classifications that we'll look at in this course is concussion, which of course is related to the head. Concussion is basically a temporary disturbance in brain function due to normally an external trauma where a person receives contact to the head. The brain makes contact with the inside of the cranium and some damage is caused. Usually a short-term problem which affects basic motor skills and speech and those kind of things, but as we've recently come to know through some longitudinal studies, that it can have some pretty awful ramifications long-term, particularly repeated concussions. So it's good to see some different organisations now putting more heed in the fact that concussion is a pretty serious injury and needs to have some ongoing sort of checks put in place to ensure that athletes' safety is paramount. And I think you'll agree if you follow rugby in particular lately that different franchises are much more open to leaving players out of team contention due to potential concussion issues, whereas before they might have rushed them back. Now they're allowing that full sort of analysis of how the player's going in their treatment and making sure that they're 100% before they come back. So Dane Coles from the All Blacks at the current time has had a considerable delay this season based on a couple of head knocks that he's had. So what are some signs of a concussion? Well, you can see a whole bunch here, ranging from physical signs such as nausea, headaches, dizziness, that kind of stuff, through to observable signs such as them appearing discoordinated, unable to focus attention or remember little events. So if they appear dazed or stunned or confused about the situation, that's a pretty good sign that they're probably suffering from a head knock. So let's dive back into our document here. You've just got to give 4 signs of concussion. You can pause the video at this point, rotate back if you wish, or look at your notes, and write down any 4 of those concussion signs that you think you'll easily be able to remember. Okay, so just getting back into the Prezi here. The next question we have to ask is, how long should a person be away from their sport or training if they have suffered a concussion? Now, this concussion document goes through some pretty useful checks as well. So some post-injury checks there, yes, no sort of questions, where if yes is indicated in one of these questions, you follow a certain path of treatment, and if no is indicated, then you follow another path. So a nice little checklist. So I'm not going to go through that now, but you're welcome to have a good look at that stuff. There's also some more general information around rehab of a concussion there too. The testable component that comes from this, and the only other question we need to fill in, is how long is the recommended length of time off sport following concussion, question 16, and right now it still stands at a minimum of 3 weeks or until medical clearance has been given. Okay, so a minimum of 3 weeks or until medical clearance has been given. Alright, so that's the classifications of injuries dealt with. We now move into prevention and treatment options for the different injuries that may crop up. So we'll dive into injury prevention. As I mentioned, this stuff is pretty much common sense. Okay, so we are going to whip through this kind of stuff pretty quickly. You can see the things we're going to talk about: managing the exercise environment and identifying hazards, making sure that we have safe equipment to use and appropriate equipment to use, making sure the people that are working out in the environment and facility that we're responsible for are personally prepared in the form of wearing the right clothes, and actually the level of exercise they're participating in is relevant to their level of conditioning, and making sure we do good pre-screening checks on the people that are involved in exercise classes and sessions to make sure we know of any pre-existing conditions that we might make worse through the process of certain exercises. Obviously, in the PT role, skill execution or technique is a vital part of our toolkit that we need to ensure our clients are maximising to avoid injury. When it comes to more team-based sports, we might look at rule adherence and obviously sticking to the rules. They're there for a reason. If you look at rugby, head-high tackles are pretty severely dealt with, as is head contact, with yellow cards and red cards in play now, which should hopefully mean less incidents of those dangerous situations. In rugby leagues, in rugby also tipping the player above parallel, putting them into the ground head first, is another example of that rule that's come in to help with that. And then probably most critically, warm up and warm down considerations. We'll talk through them. So we'll whip through some of these pretty quick, as I said. With the environment, wherever you're training someone, whether it be one-to-one or in a group fitness situation, consider the facilities, the surfaces that you're performing the tasks on, the equipment, that could be playing equipment in sport or gym-based equipment, and its readiness for the exercise you're doing, and of course if you're outside, consider the weather conditions there as well. So pretty common sense stuff. Is the facility the right size and orientation for the type of task that you're looking to do? You know, playing contact type sports in an indoor facility because the outdoors is too wet, or the surface of the grounds are too wet, and obviously doing contact orientated things on hard surfaces is not really ideal, and would be an easy way to create some contact injuries there. Slippery surfaces, ice, frost and wetness need to be considered. Playing equipment, is it the right size, is it the right quality for the people that are using it? And then of course, not that, I think sometimes people are too quick to terminate exercise sessions when the weather conditions aren't ideal, but make sure you've got appropriate equipment available and clothing available, that if the weather does turn, you look after your clients. So, again, not going to talk through each of these in turn. You guys can look at the full Prezi and talk through each of these things, but I think we've covered enough there to get an idea of what we're talking about. So I'll just whip through to the next point, which is hazard ID. Now this is testable information here. You need to be aware of the hazard ID process, and we need to be able to apply appropriate hazard ID techniques to some case study situations, which we'll talk through soon. So the first thing you need to know is appropriate hazard management involves either removing the hazard, minimizing the hazard, or isolating the hazard. Now obviously, if you can remove the hazard completely, that's what you should do. So if there's water on the floor and simply wiping it up will get rid of that hazard, then hazard removed. If there are weights left out on the floor that people could trip over, then you pick them up and put them away, hazard removed. But there are situations where you won't be able to remove that hazard completely. For example, if you've got some damaged equipment that can't be fixed on the spot and needs a specialist to come in and do it, then putting up a sign on it or making it obvious that it shouldn't be used would be a way of minimizing the risk of injury there. When you go out and you're doing boot camps in the sunshine, having sunscreen available would be a way of minimizing the risk of sunburn. If we have fluid available, then we minimize the risk of dehydration and the injuries that can be sustained through dehydration. And finally, if, for example, we can't really minimize the risk too much, but we can isolate it and make people aware of it, then that's another thing we can do. So if there was a pothole on the field where we were conducting a session, there was no way of moving to another field, then we'd make people aware of it by coning it off, taking them over and showing it and making sure they're aware of it. If there was a water leak that was dripping from the ceiling onto the floor space and we couldn't just wipe it up because it kept reappearing, then we'd put a bucket out and we'd put some sign out and some cones and make people aware of it. So whenever you're presented with a case study hazard in the assessment format, you're simply going to put in remove, minimize, or isolate as a means of dealing with it. And just be aware, if you can remove it, remove it. I will mark you down if you say minimize or isolate something. There's weights left out in the gym, just put cones around them. No, pick them up, put them away, would be the obvious thing there. So, we'll dive back into our test preparation document. You'll see there's an example thing here. We're gonna skip off a couple here and we'll come back to them at the year number 17 here in the climate ones. We're going to get it down to number 20 at the moment. So hazard ID management suggests 3 hazards that may be present in an indoor or gym environment. We've already mentioned a couple. There could be water on the floor, there could be weights left out, and there could be faulty equipment. Those are 3 pretty clear-cut ones. Underneath, suggest methods for either minimizing, isolating, or removing. We've talked through these things as well. So you can pause the video and get your answers down for that one. Next, suggest 3 hazards that may be present in an outdoor exercise environment. We've talked about potholes. We've talked about slippery conditions. We could talk about debris, stuff like rubbish or branches or needles or glass on areas where we're intending to work out. So we could talk about those things. We might even talk about traffic if we're running an event where people need to cross the road, that kind of thing. Suggest methods for minimizing, isolating, or removing each of these hazards. So choose 3 hazards that could be present outdoor and ways in which we can minimize. Other ones I've just thought of there, obviously things like the cold, the sun, and dehydration due to the sun could be factors there as well. And they're easily minimize those things. So pause the video and make sure you get 3 things down and 3 suggested methods for dealing with those hazards. Okay, so we're back into the Prezi here. And we're going to talk pre-screening for a moment. Whether you're working one-on-one with someone or in a group fitness situation, there should be some form of pre-screening that occurs. Now, this can be done well ahead of the time. If you have a good online setup for your personal training business and group fitness business, there could be an online submission where potential clients actually fill in some relevant information about themselves, and that just gives you a better picture of who you're dealing with on the day. And in a group setting, you know who you need to be most aware of. So there are many things we can put on the pre-screening, but some of the musts that should be there include their medical history, both past and sort of present, their age, their weight and maybe things like their blood pressure if they've had access to having that done recently, or if you can provide that access. It's a great indicator of internal health. Whether they smoke, what their current lifestyle is like in terms of physical activity. Are they very sedentary? Are they quite active? And what is their exercise history? And I'm not just interested in their past history, the fact they were awesome at school when they played sport, but what's happened in the last 20 years, 5 years, 2 years, and even up to this year. What have they been doing? So we get an idea of their current condition. Do they have any family history of early mortality or cardiovascular disease or high blood pressure or any of those kind of things? And is their job profoundly sedentary as well? Or are they actually quite active most of the day in the job they do? Of course, we could talk goals. We could talk a bunch of other stuff that would let us know more about our clients, but potentially in the one-to-one setting, that's going to be a lot easier to book some time to sit down and go through that stuff. But in a group setting, often they're turning up on the day, and it's something that you could have them fill out very, very quickly. Just in the paper form would be fine, or on an iPad if you have it set up like that, where you could take a quick screen of some of this critical information and know whether the session you're about to run is appropriate for them. So back into the test preparation document we go, and there's a couple of things here. We'll go down to question number 23. Suggests 3 vital areas of information gathering that should be part of any pre-screening form. And of course, we've already got age, we've got previous exercise history, we've got medical considerations, any current injuries, any 3 things that you got off that list just before could be used there. Alright, so we're starting to move into an area now where we start thinking about, well, how do we treat these injuries? I'm going to go back up to a couple of things we just missed before. So the first one, if I just go up to here, well, what happens if you're dealing with a group, a team, or an individual, and they fall and you suspect that someone has a serious head or neck injury? Now, this one is one, again, that's well outside of our domain of expertise. This is when we suspect someone has a serious head or neck injury. The key things there are really first aid orientated. All we can do is ensure A, that they're breathing, and B, that we call the emergency services and make sure we get someone who is more qualified than us in this area to come and check them out. So we don't move a person, remember, unless the risk of injury is increased by leaving them where they are. So if it was a situation where something had fallen on them from the roof or something, you may want to move them away from that area again in case something else falls on them. But otherwise, we just make sure they're stable, that they're breathing, and that we get professionals along. We'll just walk down to number 21, and again, this is about preventative work that we can do. Suggest 3 provisions you would make for dealing with a potential injury when taking a group to a remote location. So let's say you're taking your group fitness class to the beach for something, a bit of a change up before Christmas or something like that. Get them all out to the beach, do something fun, and some fitness in the environment stuff. What are 3 things that you could do to make sure that if an injury did occur, you are able to deal with it appropriately? So, some suggestions would include making sure people know, someone else knows where you're going. Number 2, making sure you have the means of contacting emergency services if the need arises. So having a cell phone and making sure there is working coverage there. 3, making sure you have a first aid kit with you so you can treat injuries if they would occur. And I would say 4, make sure someone there knows how to use that first aid equipment. No use having a box of first aid if no one knows how to use it. We could also put down things like sun cream, we could put down things like having fluids available, all that kind of stuff. So any 3 provisions that you could do that come from that list would be absolutely fine. Okay, back into the Prezi, and again we'll just whip through some of these more common sense type ones. Technique. It goes without saying, that's your job as a PT, to ensure that the technique that your clients are using is not going to be the cause of any injury. Okay, things we should probably think about most are back injuries are a common complaint. So if there's any hip hinging or loading or picking up weight off the ground, making sure they know the appropriate way to do that. But all sports and all forms of training have appropriate techniques, and it's your job to ensure the safety of your clients. Okay, so whether that's in a sport situation or whether that's in a training situation in the gym or in general conditioning, you need to take responsibility for that technical knowledge. And if you're working with athletes and they have particular needs, like a scrummager or someone like that, then you need to do some research and make sure that you're up to date with current techniques. And if it's well outside your brief, then get in someone who can help you with that sort of information. Again, rule adherence. I guess in the gym this just means being really consistent with your message to your clients. So things like footwear, appropriate footwear for the thing that you're doing. Okay, you'll provide the appropriate surfaces and environment. They need to provide the appropriate footwear and the appropriate clothing. Okay, so having like dangly earrings and long necklaces and things that get caught in machines potentially, rip out earrings and that kind of thing. It does happen. And appropriate gear. I know it's a lot of people. It's all about looking good in the gym and wearing the stuff, and make sure it's conducive to the type of exercise that you're doing. And then probably the most important one is the warm-up and cool-down process. You know, these are two things you have active control over as a personal trainer. You have to ensure that your clients are warmed up prior to doing exercise of any intensity, particularly those more deconditioned athletes who are far more at risk of doing soft tissue damage. So the warm-up is the way to do that. Now the warm-up should probably be significantly longer than what you probably think a warm-up is. Okay, to be an effective warm-up, number one, a person should be breathless. Number two, their body temperature should be elevated. Okay, and the purpose of the warm-up is to try and get the blood warm, because blood will travel everywhere and warm up the tissues it flows through. How do you know if someone's blood temperature is increased? The answer to that is they'll be sweating. So a warm-up is not effective unless a person is breathless and they have a light sweat on. Warming up improves the blood flow to the heart, reduces muscle and tendon tension, and increases the pliability of muscles, which means they're less likely to succumb to force. So it's a no-brainer that you need to do this extended form of warm-up with a client. Now, some people might say, well, what about, I've only got half an hour with the client. Can I really do a 10 or 15-minute warm-up with that client? And the answer is maybe not. So what you have to do initially is make sure you have a longer session where you show them appropriate warm-up techniques, and then ask them to turn up for their session a little earlier before you come on board with them. So they have a half-hour session, get in there 15 minutes before, and make sure they're doing their own warm-up before they come to you and start the actual lifting phase or intense phase of the workout. And if you notice that client has been standing and sort of talking, hasn't done the warm-up, then too bad. Your professional obligation is to make sure that you don't injure this person. So the first 10 minutes of that half-hour session is going to be a warm-up, and they'll soon catch on that this is something that's non-negotiable, that they have to do the warm-up. And you need to ensure this, because if you injure a client on your watch, it's literally the worst thing you can do. There is a direct correlation between lower muscle temperatures and increased muscle stiffness. And not only does that affect your performance, but it actually means that you're at a higher risk of tearing that tissue, so more susceptible to injury. So a load of studies have been done on this, and there's a clear correlation between muscle temperature and soft tissue injury. The cool down is probably the most neglected part of a workout. People, you know, in droves around the country and around the world, finish their workout, lift that last rep, finish that set of running or whatever it is they're doing, and grab their gears and go. Now the cool down is a vital part to ensuring that the muscular soreness that occurs following the session isn't debilitating. And this is most important for those new people to exercise, where you'll remember one of the first times you did a session, or the first time you do a session after a long break from it, that it leaves you pretty damn sore. And if you're not used to that and not expecting that, then they could actually think that the PT doesn't know what they're doing and has actually caused, you know, a lot of damage to them. So number one is about choosing an appropriate level for them to exercise, so they don't feel that ridiculous level of soreness in the post workout period, and that comes with experience. And then number two, you're handicapping yourself as a PT if you don't make sure these people cool down. And again, initially in the 1 hour sessions, it might be you taking them through an appropriate cool down and insisting that they do that. And then once you can trust them to do that, sure, the half-hour session, they may be at the gym for a full hour, 15 minutes of warm-up on their own, half an hour with you doing really effective sort of main workout stuff with them, and then 15 minutes at the end where they stretch and and bring their body temperature back down. Okay, this is also the time where you're able to take your muscle length back to the level it was before you started the session. So you're not going to make flexibility improvements in the post-workout period. That would take a sustained period of stretching on a regular basis in another part of the day. But during sessions, your muscles do shorten and tighten as you work the muscles, and it's about getting them back to their original level before they cool down completely and are more resistive to that. Alright, so pretty common sense type stuff when it comes to prevention. It's time to delve into the treatment options next. So we're going to look at primary treatment, which is essentially the first 48 to 72 hours, and actually the most critical part of injury treatment. Then we'll look at some ongoing treatment options. We'll discuss a few home remedies, and then of course the last resort is surgery if all of this other stuff hasn't worked, or if the injury is severe enough that just doing those modalities isn't going to help. Treatment should always be focused in this order. First thing is you want to assist healing. So you've got to do everything you can to allow that healing to happen. The thing that athletes do, and I'm guilty of this myself, is that we try to come back too quickly from injuries, and that essentially prolongs the injury process. If we just allowed it to get through its healing process, the body's pretty good at fixing itself, but we typically come out and try to do things far too soon, and that causes more damage and then delays the healing process. Once we've got that initial healing underway, then we can look to regain the length and strength of our damaged tissue, and then finally try to regain the function that we need to participate back in the sport or training we're doing. And this is where things break down a little. We go and get assistance for the initial healing. We go to physios and we get that initial stuff done, and they help us to start to regain the length and strength of damaged tissue. But then as soon as we feel like we're able to go out and join our sports team, and that again, away we go. We tape ourselves up and we get back out there. We haven't actually brought it back to the level it needs to be functional again. So let's have a look at the process. First 24 to 48 hours, the most important part of injury healing. Okay, and so many of us do this poorly. We might put ice on, but we do it once, and we do it for 10 or 15 minutes, and then we don't do it again. So we have to understand a couple of things. Number one, there is damage to blood vessels in a soft tissue injury, and that's going to cause blood accumulation, and we're going to cause swelling and compression, and all of those three things actually lead to further damage, okay, or at least delayed repair. So if we can minimize the amount of blood flow that seeps out of the damaged blood vessels, if we can minimize the swelling and compression, we can get to the healing a lot quicker. That's the premise of the first couple of days after a soft tissue injury. So what do? We're going to look through a couple of acronyms here that are going to help you remember these things. So first thing we see here, Dr. ABC. Well, that's the first thing you do when you come across an injury. So the injury's just happened in the gym, or it's just happened out in the sports field. We make sure, obviously, that the danger is cleared, that they're responding to us, their airways, breathing and circulation is all happening. Okay, so that's a given. 9 times out of 10, they're going to be perfectly fine otherwise, except for this painful area that they've suffered, like a sprained ankle, etc. We then come across toe taps, which is a acronym that represents the process of steps you should go through before allowing a person to return to training. Because sometimes we do get stingers and we do get contact and it hurts initially, and then after that initial wave of pain goes, you realise, okay, it's not as serious as I thought and I'd like to continue. But we should have a checking measure in play to be able to deal with that stuff. So I'm just going to take you into the test preparation document, and we're going to start with question number 24. When an injury occurs, you can employ toe taps. What does toe tap stand for, and what happens at each stage? Now, this info, for this one, you want the ACC. Get yourself in working order. Pamphlet here. And you'll see that toe taps is the first one on the left here. TOTAPS. And we're going to write these in on our test preparation document. The first thing you're going to write is talk. And then next to it, we're going to put a simple purpose. What is the purpose of this this first phase? So talking is to find out what happened and where it hurts, basically. So find out what happened and where it hurts. The second thing we do is observe. Before we dive in and start trying to touch the area, look at the area and see if there's any obvious signs of injury. Is it red and swollen? Is there blood? Is there a bone sticking out? And make sure you look to see that it's different from the other side, okay? If you look at an ankle, you go, oh yeah, that's a badly swollen ankle. And then you look at the other ankle, which is equally as swollen or fat, and you realize, okay, they've just got fat ankles. It's not actually that much different to the other side. So a comparison of sides is a really effective way of determining whether something's badly wrong. Once you've observed, and I should mention at this point, you don't move on to the next point of the chain if you've noticed something that should prevent you doing that. So for example, if you observe and you see a bone sticking out, you don't then move on to touching the bone. Obviously we've ascertained there's a serious injury and we need help at that point. But if there's nothing obvious, we touch. And it says here that the touch will indicate warmth and inflammation, that kind of thing, but also assesses pain. And what that means is we're actually looking to gauge their reaction. So the big thing with touch, if you say, oh, I'm just going to touch that, and they recoil in horror, that's a pretty good indication that there's something pretty bad going on there. Okay, if they won't let you actually touch it, that's a point where you'd say, okay, stop, we're not going back out there. If they allow you to touch it, then the next step is to ask them to move the injured part. So say it was an elbow that was causing the trouble, or a shoulder, you would ask them to just put it through its range of motion. So a little bit of flexion, extension. Now if it's a shoulder, a bit of abduction, put it through its range, nice and gently, themselves. Okay, so see how prepared they are to take it through its range of motion. If they're not prepared to take it through its range of motion, or it really hurts when they move it, stop. And that's it for the day. They're not continuing. If they are quite willing to take it through its range of motion, ask them to then relax. You take hold of the body part and see if they'll let you take it through the range of motion. So this is where you move the injured part through its full range of motion. So the particular areas we're interested in here is, will they allow you to take it to the extent of the range of motion, or does that cause pain? If pain is indicated, stop, and that is it, game over. Finally, if we go through all that and we've got full range of motion back again, pain-free, the next thing we need to do is a skills test. We need to identify what the skills are they need to be able to do to continue. So if it's a basketball game, it's obviously running and jumping and sidestepping and all those kind of things. If it's in the gym and they were doing bench press, then it would be deloading the bar and actually going through the bench press movement that caused the pain. And can we do that pain-free? And if it is, we can start to build up the weight slowly again. And we've probably identified it was just a bit of a stinger where a tendon might have got jammed between a bone or something like that. Can happen on occasion. And there's no lasting damage. And away we go. So that's toe taps. If we can make sure we've filled that in on this list here with the word and one little sentence about the purpose there. Okay, 25 we can cover right now. What is the purpose of the initial treatment strategy, the first 24 to 48 hours? And that is, of course, to reduce swelling and bleeding. That's the key there. Reduce swelling and bleeding. And we're going to skip down to number 27 next, because we've got our Sport Smart document open here. We're going to write in what is the price method. Now the first one, the price method, probably won't come up on this document here. We're going to have to put in the P, and the P stands for prevention. Okay, but in most cases, prevention is too late, because we're now looking at employing the RICE method, which is how we initially treat. And the RICE method is here in the middle. Once we've done the toe taps, we've assessed it, we've determined there is an injury. Next thing, if it's a soft tissue injury, is the RICE method. First, rest. You know, don't walk around it. Don't try and walk it off. Don't try and run around a bit and see if it dissipates. Rest. You've got to stop moving. The more you move with an actual injury, the more damage you're going to occur. So rest is the most important thing. Next, ice. With swelling and bleeding, the most effective way to stop that or reduce the swelling and bleeding is to apply ice, which will vasoconstrict the blood vessels, and obviously the ones that are going to the area and the ones that are broken, and therefore limit the amount of blood that seeps out. Okay, we'll also hold at bay the inflammation process. That works best if there's also some form of compression associated with it. So wrapping an elastic bandage, a firm bandage, or a tea towel or something around it that's going to hold it in place is really important there too. We can also limit the amount of blood flow that gets there by elevating the injury. Okay, so we elevate it to help stopping that bleeding and swelling from occurring as well. So the ice portion of this, the ice, compression, elevation, can all be lumped together when we talk about the purposes of these phases, and those purposes are, of course, to reduce bleeding and swelling. And the final one is diagnosis, which is go and find out what's actually wrong. It's easy to think, you know, oh, I've sprained an ankle, yep, had one before, but how do we know that we don't have a fracture? So not really the time, unless it's really, really debilitating. I'd go to an emergency department or a 24-hour clinic or something like that, but otherwise there's not much people can do for you in that first 48 hours until that swelling is kept down. So the best thing you can do is the Rice method for that first 24 hours to 48 hours, and then of course you should go get it checked out and make sure it is what you think it is. The main reason for that is not actually just the diagnosis, but to get an appropriate treatment plan. So you make sure you're doing the right things to get it better. So we drop into here, guys. We've got prevention, we've got rest, ice, compression, elevation, and diagnosis. The rest one we're going to put as a purpose to avoid further injury. I, C, and E here, ice, compression, elevation, bracket them all. They're all to reduce swelling and bleeding. And the D, diagnosis, is to get an appropriate rehabilitation plan. That's the most important thing there. Okay. Primary management of injuries is almost always the same, that first 48 hours. You always see here, regardless of whether it's a ligament, muscle, or bruise injury, the initial treatment is the first thing that happens. That's the Rice method. Then things might change in the rehab phase. You can see different things here, electrotherapeutic modalities, massage, flexibility, etc., etc. I'll explain what these are in just a moment when we get to the different rehab options. Okay. One option might be immobilization to make sure that you don't move it. That would usually only be indicated for fractures. We don't want the bones displacing. And also for ligament detachments and things where surgery has been indicated as well, where we want to hold things in position until the healing has occurred. There are downsides to having a cast on. Joint stiffness. You get cartilage degeneration because you're not moving it. It doesn't maintain the cartilage that's there. And also muscle and bone reduction can occur. It's thought that as much as a third of bone and muscle mass can be reduced in 6 weeks of immobilization, particularly in the older population set there. There are different ways of immobilizing though. You don't have to put a cast on, and a lot of doctors are now loath to put a cast on for too long, so you can have protective mobilization using braces or taping. You can also have some slings and those kind of things as well, and everyone's familiar with moon boots and those kind of things these days. These are all ways of immobilizing the joint to allow the healing to occur. So ACC suggests there are 3 phases for return to sport. We've been talking about the first one, the acute phase, and that is the Rice method phase. The initial treatment phase is known by ACC as the acute phase. Okay. The second phase, after we've done the Rice method for 48 hours and we've avoided doing too much on the injury, is to go through the rehab phase. And this is where you would see a physio or an injury specialist and try to restore things that back to their normal strength, stability, flexibility, and that kind of thing. Get your confidence back in using that. This one's often cut short. And that's often to do with funding, because physios get X amount of funding for different injuries, and when that runs out, they give you a list of exercises and say, well, you go away now and look after it yourself. And you do them twice, if we're honest, and then you just go back and start playing your sport and training again, which obviously twice is not enough to regain the length and strength. And that's why there are so many reoccurrences of the same injuries. You know, people that injure one body part once often injure it again and again over time because they never rehab it properly. Phase 3 is almost non-existent in this country. There's no funding for it. Restore sport-specific skills. This is where someone like a PT could take you and take it to that next level where we look at the movements of the sport that you're getting back to and really do some work around those specific sports to make sure that when you load the area that's been injured that you're doing it at a level where you're building up towards getting back to where you were, rather than just turning up again and having a go, you know, which is pretty much a surefire way of getting injured again. So we're back into our list here, guys. We're just going to whip it down. Oops, sorry. We are going to whip up. And we've got number 26 here. What are the 3 phases for ACC's return to play? We've got acute phase, rehab phase, and return to play. And can we provide 2 purposes for each stage? Well, the first one, the acute, is pretty easy. It's reduce swelling and inflammation again. Number 2, rehab could be restore strength, restore confidence, restore range of motion, those kind of things. And 3 is to practice sports-specific skills or training-specific skills before going back to sport. Alrighty, so we're getting there, team. Not too long to go now, so bear with me. Ongoing treatment. In the test, you're only going to be asked for a couple of things. So what are 2 things you could do maybe after the first 48 hours has gone by? And here are some options for you here. So this one could actually be included in many cases during that first 48 hours for pain. So this is paracetamol and codeine and these kind of things. So you get the over-the-counter type ones. Anti-inflammatories might be another thing that you might take alongside the RICE method just to help sort of retard that process a wee bit. And they can be bought over the counter, and as long as they're only used in short bursts, they typically don't have any associated negative effects. Just watch the aspirin. Don't go for aspirin because aspirin is a blood thinner, and therefore if you're in that bleeding phase, you certainly want clotting to occur, and you don't want to thin that blood and cause more bleeding. And codeine is a bit more potent, and some of you might have tried that. Just watch the constipation, and you know, if you're an elite athlete, you've got to be aware of what's on that banned substance list as well, so be aware of that. You can get rubs. So as you're getting back into the rehab sort of phase, they're using a topical analgesic, which is like a deep heat or a tiger balm or something like that. But just be aware, if you have niggles and pain and muscle soreness, if you're rubbing that stuff on your skin, it doesn't penetrate deep into the muscle, okay? So the way they actually work is it stimulates pain and heat receptors on your skin, which is kind of like a misdirection for your brain. It starts thinking about that, and then it dampens down the feelings of the pain and so on from within your muscles. So people think, oh, yeah, that's better, that's fixed it, but it hasn't actually fixed it. It's just a brain redirection type tool. Topical anti-inflammatory agents, though, things you rub on like Diflam and Voltaren and that, are actually equally effective as oral. They do get into your bloodstream. Everything that goes into your skin, onto your skin, goes into your bloodstream, and so can be useful. Never spend loads of money on targeted pain relief. You know, when you take a pill for back pain relief, your body doesn't know that it's specifically designed for the back. So don't spend extra money on specifically targeted pain relief. It's just a bit of a waste of money. Alright, so these things collectively, particularly when you can get them over the counter, are known as NSAIDs, non-steroidal anti-inflammatory drugs. Okay, so these are things that help with pain and help to reduce inflammation. Just watch the ibuprofen and anti-inflammatories long term. If you're taking them long term, you've actually got to ask, why do I need them long term? Is there a chronic injury there? They can have gastrointestinal symptoms associated with them. The thinning of the gut lining and stomach ulcers has been indicated with long-term use of those. So you don't want to need them as a crutch, basically. If we've gone through the initial phases and some rehab, and it's been indicated by someone that maybe we're not dealing to that inflammation as well as we could be, you could be offered a corticosteroid. So that's an injection into usually a joint space, and it's a potent anti-inflammatory agent, so it gets in there and basically frees stuff up very quickly. It's often used at a point where the initial healing has happened, but there's still some restriction and movement there. So just to get things freed up and give a bit of confidence to use that body part again, corticosteroid might be whacked in there by someone who knows what they're doing. To help manage pain and help work out muscles when you can't actually move an injured part, these things can be useful. So electrotherapeutic modalities, some of the physios use the muscle stimulators. A neuromuscular electrical stimulator basically contracts the muscles by firing electrical stimulus at them. That can be useful if you have a broken lower leg, but you want to keep your quads and hammies in check. And they were pioneered really by Norwegian skiers who, when they had a broken leg and were in a cast, would put those things inside it, and it would work away on those muscles and keep some of their muscle mass in there while they're inside the cast. So pretty useful. TENS machines are more pain blockers, so that's for ongoing pain. The pads are placed either side of the spine and basically scramble the messages of pain that get through, so it dampens down your pain. Again, that would just be for the resting period, not something you would use to get you back into sport. That would be in that initial sort of painful time frame. Manual therapy is the domain of physicians and physiotherapists, chiropractors. It's not our domain. We shouldn't go rubbing things or pulling on things on our clients if we don't know what we're doing. So it's administered following a careful clinical assessment, which needs considerable study and is not part of our domain. But people can obviously go off, and you might have referral pathways for sending people over to these kinds of professionals. These are some of the things that physios would do. So everything from neural stretching through to manipulation and thrusting and traction and all these kind of things. Is it useful for you to know these? Probably not, unless you're going to go into some further study around how to do some of these things here. And then there's some more holistic, or I guess non-mainstream versions of pain relief and muscle activation, and acupuncture is one. And I'm a huge proponent of this, purely from anecdotal evidence. I've found some great benefit in having acupuncture done in areas that have caused me long-term sort of pain and imbalance. So yeah, if you ever get the opportunity, worth trying. You know, what's the worst that can happen? You get a couple of pinpricks in you, and the best side of things is it may cause an improvement to that soft tissue injury that you weren't getting through traditional methods. So still a cause of much debate, but a lot of anecdotal evidence there to suggest that it could be helpful. Alright, so we'll just jump back into our notes here. We've got a simple question on ongoing treatment methods. We've got our initial treatment strategy there. We should be able to go down. And number 30 says, suggest 2 methods of treatment that can be employed after the first 48 to 72 hours. Your options include cortisone injections, massage therapy, physiotherapy. We could put in there acupuncture. So a bunch of things, and even things like heat-cold treatment, which we'll talk about soon, that you wouldn't do in the first 48 hours, but you can do in the second. Okay, so just 2 little bits to go, guys. I promise you we're almost there. Just a couple of things we need to pull out of these last couple of slides. So we'll look at some home-based remedies now. The ones that you can do from home are obviously heat and cold. So we'll look at the use of those. We've already talked about the benefits of ice, been around for a long time, and this knowledge has been around for a long time. It's easy to get hold of, cheap and available if you have a freezer at home. And like I said earlier, vasoconstriction is its key tool, and that is the constriction of the blood vessels. Other benefits include decreasing the metabolism that occurs there, so that reduces the sort of heat energy that the muscle makes through its normal metabolism, and reducing the inflammation so that the healing process can go on. And the added benefit is once it's numb, it usually doesn't hurt as much. So we should use ice as the primary management tool for all soft tissue injuries. Heat has its applications. It obviously does the opposite, which is vasodilation. It opens up blood vessels. So you don't want to be doing that when the blood vessels are healing in that initial stage, but after that first 24 to 48 hours, particularly minor injuries, soft tissue injuries like minor tears and bruises and those kind of things, are a real useful way of getting blood flow to return to the area, and we can adapt hot and cold type treatment to help that process of bringing good nutrients in with good fresh blood, and then take away the bad stuff by causing it to go away through the use of cold again, so we can bring it in and take it out. We shouldn't apply it though in the first 24 to 48 hours because of its heat and blood bringing properties. And the alternating between hot and cold has been used for a while now in the form of contrast baths. So a lot of sports teams have used the cold therapy, so getting into a cold bath, and actually very recent research published this year in 2017 has shown that there's probably not as much benefit as people thought to that process. So really the hardship of putting your athletes through that sort of cold ice bath after the game is shown to have very little effect on the next bout of exercise that they do. However, if there's injury, soft tissue injury involved, then of course the application of ice and then the contrast use of heat and cold could be a very useful way of diminishing pain in the muscles after exercise. So we're really talking about not necessarily injury here, but DOMS, the delayed onset of muscle fatigue that occurs through a hard workout. The process is just written below there. So Start with a hot bath, 2 to 3 minutes, and then cause that sort of shock to occur and the blood to leave the peripheral areas by jumping into something pretty cold, as cold as you can endure, for about 1 to 2 minutes, and then repeat that up to 3 to 7 times, finishing with the cold bath, which no one wants to do. Everyone wants to finish in the spa, but finishing in the cold bath and then letting your body return to normal slowly is found to be the best way to do that. And then, of course, the last resort. The last resort is surgery. Now, before we kick into the surgery, I just want to go back to the test preparation document, and we'll roll up here into ACC's avoid harm. So ACC's avoid harmful factors. This is a little acronym they come up with things to remember to avoid in that first 48 hours. If we click back into our Manage Your Sports Injury document here, the ACC one, avoid harmful factors, you'll see that H stands for heat, A for alcohol, R for running, and M for massage as things we should avoid in the first 48 hours. So the heat we've already discussed because, of course, it increases bleeding to the site. Alcohol is a blood thinner, which will cause more bleeding, and it also masks the pain if you have a few beers under your belt, and therefore you probably do stuff on that injured area that you shouldn't do. So I've been to a lot of places where I've seen footy players with their cast on and their crutches having a dance on the dance floor, which is obviously not conducive to good healing. Running actually represents any form of exercise that will use the body part and cause further damage. So you shouldn't resume any exercise on it until at least the 48-hour period or 72-hour period has passed. And massage to the actual area will cause more damage, effectively. Yes, it will increase heat, bleeding and swelling, but could actually just tear more fibres of the torn fibres that already exist. So rocking into here, we make sure we've got heat, alcohol, running and massage, and a little sentence about why. In fact, the question below is where you can put in the ones that are testable. You'll only be asked about alcohol and massage. Why should we avoid alcohol and massage in the first 48 to 72 hours? We should avoid them because they increase bleeding, thin the blood, and the alcohol, of course, makes you do things that you probably shouldn't do on an injured body part. Massage can cause more direct tearing to the injury site too. Alright, so we've only got a couple of things left. At this point I will actually go in and something I should have covered earlier, and you'll see that we've missed them. 3 personal preparation strategies. So just as we recap here, what are 3 things that people should do before they engage in sport and training to reduce the chances of injury? Of course they should warm up. Of course they should know the techniques of what they're involved in. Okay, and you could put down as well the cool down factor there in as well, but also being prepared, not only with the technique, but being prepared physically for what they're about to take part in. Have they got appropriate condition? So warm up, learn the techniques, and appropriate condition. A little bit of repetition really from what happened earlier. The only other things we haven't covered are the causal relationships between climate and exercise. We've talked through them, and we'll just fill these ones in. This is where it's another bit of recap, and I didn't want to do it at the same time as hazard ID management because it is effectively the same thing. But let's just brainstorm quickly some relationships between climate and injury. Climate, of course, is weather, so heat would be your first one. And the relationship between heat and potential injury is heat exhaustion, heat stroke, dehydration. Those are heat injuries that could occur. You could go cold, and the injury that could occur through cold is either having less pliable muscle, so more risk of tear, or hypothermia, which is a weather-related injury it's classed as well. And maybe the third one could be wet, so if it's raining, and that could lead to a slip and an actual injury. It could be something like a broken bone or a sprained wrist. So we have to link an actual injury in. What about the exercise environment? Well, that could include outside or inside. So we'll use those ones we used before. There could be glass on the ground. So the injury would be a cut. There could be weights left on the floor. You could trip and stub your toe or break your toe. And there could be water on the floor, and you could slip and bang your head on something, causing a concussion. So any 3, not something you need to study out much, this one, guys. Just make sure you've got a clear relationship between weather and how an injury can occur, and the exercise environment and how an injury could occur. Cool. And that leaves us our very last bit. You'll be glad to hear. We'll whip through this quickly. Some of you may have had surgery before. There are two different types, arthroscopic and open. The benefits of arthroscopic are obviously that you don't have to open the person right up, which limits the risk of infection. There's arthroscopic keyhole surgery. It's amazing what they can do through a little keyhole these days. And there is the alternative, which is open, which would be last resort because of the amount of tissue damage you have to do to get to the part that you're aiming for. So, last couple of slides to finish off here. Who can legally diagnose injury? And there are only 4 people: physiotherapists, medical doctors, medic, and St John ambulance medic. Now, the people that would love to be on there that aren't, that legally cannot diagnose injury, are nurses, even though they probably know exactly what's going on. In many cases, they still need a doctor to sign off on that. So we'll drop down to, right at the bottom here, 31, list 3 medical professionals who can diagnose. You've got medic, you've got doctor, and you've got physio that you can chuck into that list there. Now we're taking a quick scan, making sure that we've covered everything we need to here. So we've got all of these ones filled out now. We have all of these ones filled out now. Yes, we've talked about these. We've got the relationship between the weather and that we've just done, and we've talked through all of these guys here, which means that the accessible content is complete. That is everything you now need to study up to get you through the assessment for this thing here. The accessible test has a pass rate of 75%, so we need to study up on these little acronyms and these easy marks that we can get, guys, and make sure that you are au fait with all of that. If you're in a physical class with us here at NZS, we'll be doing some in-class sort of quizzes and checks as well, and you could look out for some loaded up practice quizzes on the Moodle page below this as well. Just before you go, something that might be really useful to you when you get out into the industry is the Ongoing Injury Management Guide that ACC has developed, this tool. Again, a list of yes-no questions that you can apply to your client. So I'll just show you one example of this, and that is the ankle sprain. So you see in the ankle sprain here, it tells you what an ankle sprain is. It goes through the initial treatment of rest, ice, compression, elevation, diagnosis. And then, when we get into that rehab part, what do we consider when we're rehabbing here? Can you do these things here? So it gives you some suggested stuff that you could pass on this information to a client who maybe has rolled their ankle in a game of touch and can't come in and do sessions with you for the next week. Well, this is the kind of thing that you could pass over to them to show them that you still care and that you can still be of use to them, and that means we'll hopefully get them back on board quicker. Once you do get them back, you could actually offer to take them through the return to play or the final phase rehab, and here are some nice little yes-no markers for them. So you see here, has swelling and pain settled? Yes, begin range of motion exercises, which are on the other page. No, continue rice treatment. And then we just move through. Can you move your ankle without pain? Yes, begin these things. No, then continue with what was happening, or it might indicate they need to go see another medical professional. It goes right through days 9, days 10, days 12, and indicates, again, at what point you can be involved in this, so you can take them through some of this and get them back on their feet quicker. So they've got these for all of the key injuries, from hemi strains to shoulder injuries to all sorts of things that you could compile, and just shows the client that you care and that you've got something useful that you can show them to maximize their recovery so they get back to you quicker and you get some more money coming in from that source. Alright, thanks for listening up, guys. Apologies that this one ran a little longer than I'd intended, but all of the info is now there on your test preparation document, and you have everything you need. Any questions, be sure to email or hit me up here at NZS, and I will gladly clarify. Thanks for tuning in.